Next, let's talk about the patient's dyslipidemia condition. As the patient had dyslipidemia and stroke, we recommend the switch of a previous medication of simvastatin 20 mg, which is a moderate intensity statin therapy, to atorvastatin 40 mg, which is a high intensity statin therapy. According to Malaysia's CPG and several journals, atorvastatin given as high-intensity statin therapy can produce a greater percentage LDL-C reduction and thus reduces cardiovascular events more than moderate-intensity statin therapy. It also gives substantial long-term benefits on the prevention of adverse events after acute ischemic stroke without increasing the risk of hemorrhagic stroke. It also decreases the risk of stroke, major coronary events, and revascularization procedures. And finally, it gives more favorable early outcomes, suggesting an additional neuroprotective effect. For the monitoring parameter of dyslipidemia, we should first monitor the lipid profile, which include LDL, HDL, and TG, to ensure that it is at a normal level. Next, we should monitor the liver function tests, which include ALT, AST, and serum albumin. Finally, we should monitor signs and symptoms of increased creatine kinase, which suggests myopathy, which include muscle pain, cramping, stiffness, weakness, and fatigue. Now, let's move on to the pharmaceutical care issues and drug-related problems. The first PCI is the patient's potential medication adherence issue or insufficient control of diabetes mellitus with previous medications. This is because the patient's dextrose and HbA1c level were high upon admission, although the patient was on 3 diabetic medications previously, which were metformin, gliclazide, and insulin mixed. Therefore, we should detect for adherence issue and assess the insulin injection technique of the patient. If the patient has no adherence issue, we may need to increase the dose of the insulin or change the regimen of anti-diabetic drug appropriately based on guideline until blood glucose level is controlled. We should also monitor the patient's blood glucose level and HbA1c, preferably once every 3 months. Also, we need to educate the patient to identify the signs and symptoms of hyperglycemia or diabetes, which may include increased thirst, frequent urination, and fatigue. The next PCI is the lack of ECG monitoring, although the patient had hypokalemia. According to Clausen and Catalyst, hypokalemia carries a greater risk of cardiac arrest than hyperkalemia. Therefore, repeated monitoring of plasma potassium and the electrocardiogram is important. To manage hypokalemia, first, repeated monitoring of ECG is required to identify any prolongation of the QT interval in the electrocardiogram. Next, we can give oral potassium tablet of IV potassium if the patient is not tolerating orally. Next, we should avoid drugs that can induce prolongation of QT interval, for example, antihistamine and antibacterial. As for the monitoring, we should monitor symptoms of QT prolongation, which include unexplained fainting, unexplained drowning, and unexplained sudden cardiac arrest.